Yeah.
For intestinal obstruction, ma'am, that content cannot pass through the GI tract.
Yeah. Okay. So it is GI tract, meaning GI tract starts from right from your mouth, no? But here there,
Uh,
yeah. So
from
basically,
stomach to intestine.
so basically in the intestines, no, it is not talking about
Yes, ma'am.
other organ of your GI tract.
Yes, ma'am. Yes.
Okay. So the definition, intestinal obstruction exists when there is a blockage that prevents the normal flow of intestinal contents through the intestinal tract. Okay, as simple as that. So there is some blockage, there is some obstruction. So the intestinal contents don't move ahead into the intestine, thus affecting the digestion process. Okay, so there are two types of processes that can impede this flow. First is either it is a mechanical type of obstruction or it is functional type of obstruction. Okay. So what is mechanical? Mechanical means something in the within the intestine which is causing the obstruction. Okay. So it is an intraluminal obstruction or a neural obstruction from pressure on the intestinal walls. So example, it can be intussusception, any sort of tumors like the polypoid tumors, neoplasms, stenosis, strictures, adhesions, hernias and abscesses. Okay, so that is called as mechanical obstruction. Second is the functional obstruction. So the intestinal musculature, that is functional meaning something to do with the function. So function is not happening properly. What is the basic function of the intestine? It will move the whatever contents it reaches to the bowel, it has to move it forward for the absorption and the remaining digestion. Okay, then so what happens here is the intestinal musculature cannot propel the contents along the bowel, right? So the whatever intestinal musculature meaning the muscles, okay, which will constitute the intestinal wall, they are not doing their function properly. So example, in which cases it can be seen, it can be seen in the patients who are suffering from amyloidosis, muscular dystrophy, endocrine disorders like diabetes mellitus, neurologic disorders like Parkinson's disease. Okay, so this blockage can be either temporary and it can be as a result of the manipulation of the bowel during surgery. Okay, so remember intestinal obstruction, two types, two processes which occur here. One is mechanical obstruction or the functional obstruction. So this obstruction, it can be either a partial type of obstruction or complete. Okay. But about its severity, it will depend upon how much lumen is obstructed because of that whatever is the obstruction. Okay, especially the degree to which the vascular supply to the bowel is disturbed. Right. So we said the two processes, it is mechanical and secondly it can be functional, it can be partial or it can be complete. Fine. So most bowel obstructions occur where they occur in the either in the small intestine or you have it is in the large. Okay. So when it is there in the small intestine, what are the causes of it? Mostly the adhesions which are there present in the small bowel, they may cause, which is happening because of hernias or certain neoplasms. Other causes, what are they? Either in the cases of intersusception or if there is a volvulus. Okay, intersusception meaning what? The loops of the bowel go within each other. Okay, so that is intersusception. And volvulus is what? It is twisting of the bowel. So either of these cause or there can be paralytic ileus. Paralytic ileus, that means there is no nerve supply to the ileum and there is because of that the function is affected. So that is what it may occur in the small intestine. What happens in the large bowel? Okay, or the large intestine. Here it is less common than the smaller intestine. It is only 15% of the intestinal obstructions will be seen in the large bowel. Most of these are found in the sigmoid colon. Okay, these the most common causes are carcinoma, diverticulitis, inflammatory bowel disorders, and benign tumors. Okay, so either of the intestine can be affected. If we see a tabulation of mechanical causes of intestinal obstruction, these are the common causes: adhesions, intersusception, volvulus, hernia, and tumor. Okay, you can find the explanation. What are additions? Here, the loops of intestine become adherent to the areas that heal slowly or scar after the abdominal surgery. So, mostly after the abdominal surgeries, patients may develop additions. Okay, so what would these additions do? They produce a kinking of an intestinal loop. Okay, so that is how the obstruction is caused. Secondly, with the intersusception, what happens? That is the one part of the intestine slips into the another part. So like how you have a telescope shortening. Okay, so when you close a telescope, how it goes within each other, within it. So that is how intersusception would be seen. So if this occurs, then there is a narrowing of the lumen. Then volvulus means what? The bowel will twist and turn on itself. So in this case, again it will obstruct the lumen. Gas and fluid will accumulate in the trap bowel. Then hernia is what? Protrusion of intestine through a weakened area of the in the abdominal muscle or wall. So it will result in, again, if at all, it may get completely obstructed, and also blood flow to the area will be obstructed because of that. Then what about the next cause is the tumor. The tumor, as you know, it will occupy some space in the intestinal lumen. Okay, so tumor outside the intestine or even within the intestine, either of it. So outside, if it is there, then also it will cause pressure on the wall of the intestine, and if it is inside, it will extend inside the lumen. So that will cause the obstruction. Okay, so it may become either a partially obstructed, and if the tumor is not removed, it will go on increasing in size, and there will be complete obstruction. Okay, these are the figures. Not where you can see what is this. This is moving into the other. It is forming a loop inside the intestine. So this is intersusception. Okay. Here there is a, see, there a loop of the intestine is formed and it has got twisted. So this is your volvulus. Okay. And third, when it will, the part of the intestine will slip out, right? So there is a sac of the hernia is a continuation of the peritoneum in the abdomen, and the hernial contents would be here. In this case, it would be intestine, omentum, or any other abdominal contents that pass through the hernial opening into the hernial sac. So these three basic causes: intersusception, volvulus, and hernia. So if you see the pathophysiology, it is separate for small bowel obstruction and large bowel obstruction. Okay, so what is happening in small bowel obstruction? If it occurs in the small bowel, what is there in the small bowel? There is intestinal contents, there is fluid, and there is gas. Okay, because it is getting obstructed, these all things will start accumulating, and there will be abdominal distension and retention of fluid. So if this is occurring, what it is going to affect? The basic function, that is the absorption of the fluids, and it will stimulate more gastric secretion. So with increasing distension, what is going to happen? The pressure within the intestinal lumen increases, causing a decrease in venous and arterial capillary pressure. Okay. So because there is your decrease in the venous and arterial capillary pressure, what happens is it will cause congestion. Okay, so there is seen edema, and eventually it will cause necrosis, and slowly and steadily it goes on, then there will be a rupture of perforation of the intestinal wall with the resultant peritonitis. Okay, so the patient may, because it is getting obstructed, the content has to come out from somewhere. So there may be reflux vomiting, may be caused because the abdomen goes on distending, right? So vomiting results in a loss of, what is happening? So the loss of hydrogen ions and potassium from the stomach, leading to reduction of chlorides and potassium in the blood, and it leads to metabolic acidosis. Next, it is because of there is loss of all these your electrolytes, the patient, as well as fluids, the patient will go into dehydration, and acidosis will develop from loss of water and sodium. So with this acute fluid losses, the patient will end up into hypovolemic shock. Okay, so this is what is the scenario in small bowel obstruction. So what are the signs and symptoms in case of small bowel obstruction? There will be crampy pain. Now this pain will be like wave-like, and it will be colicky type of a pain. Patient may pass blood, mucus, But because there is obstruction in the intestine, there is no fecal matter and no flatus which is coming out. Okay, but it is the other way. So the patient will vomit. So vomiting is seen. And if the obstruction is complete, the peristaltic waves initially becomes extremely vigorous and eventually it will assume a reverse direction. So with the intestinal contents propelled toward the mouth instead of towards the rectum. If the obstruction is in the ileum, fecal vomiting takes place. Okay, so if it is a bit below, that is, it goes in the ileum, obstruction goes in the ileum, there will the fecal matter is formed, but then it doesn't go out from your rectum. It has to come out, so it will come in the form of vomiting. So, first the patient vomits the stomach contents, then the bile contents, stained contents in the duodenum and the jejunum, and finally, with each paroxysm of pain, the darker fecal-like contents of the ileum are vomited by the patient. Okay, so the patient may land up many times, of course, into dehydration. So the patient may complain. These are the signs and symptoms of dehydration. So the patient will complain of intense thirst, drowsiness, generalized malaise, aching, and parched tongue, that is dry tongue, and then also the dry mucous membranes. Abdomen, it is distended. Then the lower obstruction is in the GI tract. The lower the obstruction is in the GI tract, what happens? There is more abdominal distension which is seen. And if the obstruction continues uncorrected, the hypovolemic shock occurs from dehydration, and then there is a loss of plasma volume. Okay, so these are the clinical manifestations of small bowel obstruction. How would you assess and diagnose it? So basically on the symptoms, then on X-ray findings. So abdominal X-ray will be done. So it will show abnormal quantities of gas, fluid, or both in the bowel. Then the laboratory studies, because the patient goes into dehydration. So electrolyte studies are done and complete blood cell count will should be there. So which will tell that the patient is going into dehydration, there is loss of plasma volume, and there is possible infection. Okay. So what is the medical management? First and foremost required is decompression of the bowel through an nasogastric or small bowel tube, which is successful in most cases. So it will help out in taking out whatever flatus and whatever the contents are there. When the bowel is completely obstructed, the possibility of strangulation warrants a surgical intervention. Okay, so when you have some strangulated type of an intestinal loop, they have to go in for surgical intervention, because if it gets necrosed, then it is not going to help the patient but harm the patient. Okay, so if they have decided for the surgery, the patient will be put on intravenous therapy to correct the fluid and electrolyte imbalance. Then the surgical treatment of obstruction will depend on what is the cause of the obstruction. Okay, so if it is hernia and adhesions, then you have to repair the hernia. They have to break down the adhesions. Okay, where the intestine is attached. That is what is required. Then, in certain cases, what they will do, whatever is the affected bowel, they will cut it off and they will anastomose. That is, they will join the remaining intestine. Okay, then uh, the complexity of the surgical procedure for intestinal obstruction depends on the duration of the obstruction and the condition of the intestine. Okay, so that is medical management, and of course surgical management is included in it. So how you will take care of the patient? Maintaining the patient will be having an nasogastric tube. So taking out the placement of the nasogastric tube, there will be a continuous drainage from the nasogastric tube may be there in the initial period. So there will be, you have to measure the nasogastric output, assess the fluid and electrolyte imbalance of the patient. So all the values of the electrolytes, serum electrolytes, then monitor the nutritional status, monitor whether the patient is going into dehydration. Also, once the patient is improving, check out how, if the patient's bowel sounds are returning back to normal, there is decrease in the abdominal distension. So keep an eye on the abdominal girth. Subjective improvement in abdominal pain and tenderness. So keep on assessing the pain score for the abdominal pain. Check out for passage of the flatus or the stool. Okay, so if these will all tell you that the patient is improving. Also, check out if there is any discrepancies, that means there is any reduction in the intake and output, or there is uh, imbalance in the intake and output, then worsening of the pain or abdominal distension and increased nasogastric output. If the patient's condition does not improve, then here the patient will be prepared for the surgery, and then a surgical repair of the small bowel. We have to assessment pre or post op, everything will be the same as for any abdominal surgery. Okay, that was with small bowel obstruction. Now, if the obstruction is in the large bowel, so here what happens? There is again same thing. There is intestinal contents are there, fluid and gas. So whatever is proximal to the obstruction of the large bowel, it will start getting accumulated. It will lead to severe distension and perforation unless some gas and fluid can flow back through the ileal valve. Okay, so there is large bowel obstruction. If it is complete, it may be undramatic if the blood supply is to the colon is not disturbed. But if the blood supply is cut off, then what happens? There is intestinal strangulation and necrosis. So necrosis is going to cause the tissue there. So then this condition becomes life-threatening. Okay. Only here in large intestine, what happens? Dehydration occurs slowly than in the small intestinal obstruction. Okay, why? Because the colon can absorb its fluid contents and can distend to a size considerably beyond its normal full capacity. Okay, so that is the difference between a small bowel and a large bowel obstruction. So the signs and symptoms will be a bit different. Okay, here vomiting will be present. Will it be present? Not initially. Okay, so it is, these symptoms will develop and progress relatively slowly. So here, if the obstruction is in the sigmoid colon or the rectum, the patient will have constipation. Okay, that will be the only symptom which is seen for days together. And slowly, eventually, what happens? The abdomen becomes distended, markedly distended. Loops of the large bowel become visibly outlined through the abdominal wall, and the patient will get crampy abdominal pain. Okay. Now, then later on, finally, there will be fecal vomiting which will develop. But again, the patient may move into the shock. So symptoms of shock may occur. There are clinical manifestations of large bowel obstruction. What about the diagnostics? It is based on the symptoms and on the X-ray studies. So X-ray studies, patient has to stand flat and upright. So it will show a distended colon, and barium studies are not done. Okay, why barium studies will not be done? You know what are barium studies, no? Why do you think barium studies will not be done? Why they are contraindicated?
Because because of the intestinal obstruction, the dive is used in the barium study. We cannot push or
Yeah,
from
so
the
it will not be
yeah
excreted out from the,
extracted from the body.
yes. So
It
it
will
is
not
right,
eliminated from the body.
right. So it is
Mhm.
contraindicated. Okay. So how would one manage such a patient? First is again colonoscopy is done to untwist and decompress the bowel. So here it can be used with as a therapeutic use. Okay. Otherwise, colonoscopy, it is done to visualize the colon and find out the abnormalities in it. Then there is something called as cecostomy. So cecostomy is what? It is the surgical opening which is made into the cecum, which may be performed for the patients who are having poor surgical risk, and they require some urgent relief from the obstruction. So that time, they what they will do, cecostomy will be done, and this will help to provide an outlet for releasing the gas and a small amount of drainage. Okay, that is the second procedure which may be one option. Thirdly, depending upon the area, what is the patient's problem. So either a rectal tube may be placed to decompress an area that is lower in the bowel. Okay. Then usual treatment, again the patient will have to undergo a surgical resection to remove the obstructing lesion. So temporary or permanent colostomy may be necessary, right? So here they may do an ileoanal anastomosis, which may be performed if it is necessary to remove the entire colon. Okay, so the ileum will be directly attached to the anal, or that is the rectum. So that is, in case if it is a real large type of obstruction, then they will remove the entire large colon. Okay, so that is the management in large bowel obstruction. management, nursing management. You have to again monitor the symptoms for the signs and symptoms of intestinal obstruction. If it is worsening, if the patient goes into shock and all, that has to be monitored. Then, of course, providing emotional support, because many times we said that this may be even a life-threatening situation for the patient. So, providing emotional support and comfort, administering the IV fluids and electrolytes as prescribed. And if the patient's condition does not respond to any non-surgical treatment, then the nurse has to prepare the patient for surgery. So again, your pre-op preparation and post-op care, again similar to whatever we said, but here if at all the patient has got a colostomy care is required. Okay, so pre-operative teaching would be according to the patient's condition. Then after the surgery, you have to see the that may be abdominal wound, so care of the abdominal wound and routine post-op nursing care will be provided. Okay, so that's all with intestinal obstruction. Is it clear?
Yes,
Yes,
ma'am.
ma'am.
Yes, ma'am.
Fine. We'll move on to the next topic, inflammatory bowel disease. Okay. Inflammatory bowel disease. Inflammatory, again, there is inflammation of what? Of the bowel, no? So here it refers to two chronic inflammatory GI disorders. It is divided into either it is called as a renal enteritis. So it is the other name to renal enteritis is Crohn's disease, or it is or it is also called as granulomatous colitis. Okay, and secondly, it is classified as ulcerative colitis. Fine. So two types: regional enteritis and ulcerative colitis. What are the etiology and risk factors? Again, the cause is unknown in spite of whatever they have tried to find out and long research, but still as yet there is no specific cause which is like found to cause the inflammatory bowel disease. So, what are the risk factors? These are the risk factors which have been identified till date. So there can be it can be triggered by the environmental agents, like for example certain pesticides, food additives, tobacco, radiation. Okay, then there may be non-steroidal anti-inflammatory drugs, like uh, an example, non-steroidal anti-inflammatory drugs.
Ibuprofen.
Ibuprofen. Okay. Any other? Which are given maximum in your life?
Paracetamol.
Okay.
Diclofenac.
Yeah, diclofenac, right. So many times you are seeing, no, the patient is getting diclofenac and ibuprofen. So these two common drugs. Then allergies, immune disorders, then certain abnormal response to the dietary or bacterial antigen and certain genetic factors. Okay. So this may be the risk factors when the patient may be likely to suffer from inflammatory IBD. Then first, we will see the regional enteritis. As I said, it is also called as Crohn's disease. Okay, so regional enteritis, it is more seen in the adolescents or the young adults, but it can appear at any time in the life. It is more commonly seen in women, and it occurs frequently in the older population. So mostly in the between the age of 50 to 80 years, and it can occur anywhere along the GI tract, but the most common areas are distal ileum and colon. Okay, it is, this Crohn's disease is seen 2 times more often in the patients who smoke, okay, than in the non-smokers. So this is just an introduction of Crohn's disease. What happens? What is the pathophysiology of Crohn's disease? Now, when you say enteritis, itis relates to inflammation. So regional enteritis, it is a subacute and chronic inflammation that extends through all layers, that is intramural lesion of the bowel wall from the intestinal mucosa. So it is characterized by periods of remissions and exacerbations. Okay, remission and exacerbation meaning what? What do you mean by remission and what is exacerbation? Different words, no? Hmm? Hello? Any idea?
No, ma'am.
Ramesh. No, ma'am.
Okay, remission is again it may occur, right? There may be frequent episodes of the Crohn's disease, and second is exacerbation. Okay, exacerbation. One cause what we saw here is what is that? Allergies or any immune disorder. So when if the immunity goes low, or if there is any allergy, okay, so to any of the food whatever the patient may be allergic to, so that will exacerbate meaning it is we have treated the patient is okay, but he eats something which is again causing it is a risk factor for the patient, and again the patient shows the signs and symptoms. Okay, so remission is frequent occurring of the event, but exacerbation is also frequent occurring, but it is because of certain already known risk factor, the patient will show the disease condition. Okay, so that is exacerbation. Any other disease you know which has got exacerbation?
Asthma.
Yes, very right. So asthma, it will cause. You can see the patient is okay if there is environmental issue. कुछ नहीं है. The patient is settled down. Right now, the patient is not using the puffs and all for getting the relief from the dyspnea. But suddenly, what may happen? There is some change in the weather, and the patient starts getting again struggling for breath. Right. So that is an exacerbation. Hmm? The disease process begins with edema and thickening of mucosa, and ulcer will begin to appear on the inflamed mucosa. Okay, so these lesions, how are the what is the characteristic of these lesions? They are not in continuous contact with one another and are separated by a normal tissue. Okay, then if the inflammation again it still continues on, then what will happen? Either there will be formation of a fistula or a fissure and abscess. What is a fistula? What is a fissure and what is abscess? Yes,
Fissure means
yeah.
any tear.
No, it's not a tear.
Ma'am, fistula is an abnormal connection between organs.
Okay, fine. So it is an abnormal connection between any. So it forms a hollow, what you can say, clear connection between the two organs, right? So that is a fistula. Okay. So tube-like thing, if you see, if you imagine that is inserted in between something, right? So that is a fistula. Fissure क्या है? Yes. What is a fissure?
Mm.
Develops on the skin.
Ulcer.
No, no, it is not an ulcer. What you can say, if it will be a sort of, first of all, there is a breakdown in the skin. Hmm? And that breakdown on the skin, what it is because of certain, what you can say, there is a break in the continuation of the skin, right? So that will be called as a fissure. Okay, long linings, if you can observe on if on the skin, So that will be called as a fissure. But connection when it is formed, that is called as a fistula. Okay, so that is difference between a fistula and a fissure. And what is an abscess?
First collected in
Due
tissue.
to infection.
Formation.
Sorry,
First
first.
collected in tissue
First
or
formation.
space
Okay.
inside the
Yeah,
body.
yeah. So that is because of mostly some infection. So you have your WBCs and all, they get into the get collected, and then it will cause the inflammation in that area and it will damage the tissue. Okay. So that is the, so either of these may be formed because of inflammation. Okay, as the inflammation will extend to the peritoneum, and in the go slowly steadily again it would tend to develop a granuloma. ओके, ग्रैन्युलोमा क्या है? पैथोलॉजी में पढ़ा होगा ना ग्रैन्युलोमा. You all had pathology?
Yes, ma'am.
So if you remember what is granuloma?
It is some kind of
Inflammation in
inflammation.
small area.
Yes,
What?
the small area inflammation.
Okay, so there is a
Yeah, it's sometimes benign, ma'am.
hmm.
Benign in nature.
Yeah, they are mostly they don't turn up into cancerous, no? So they are benign.
It's
Like for example,
benign.
you may see in also in cases of uh, any condition you remember granuloma formation.
The immunodeficiency disease.
Immunodeficiency disease, okay,
This is
and tuberculosis, granuloma formation,
yeah.
yeah,
Yes, ma'am.
yeah.
Yes, ma'am.
There also there is inflammatory changes. No? So here also in now in the intestine also these changes are occurring. So granulomas may be seen in certain in almost half of the patients. And in advanced cases, the intestinal mucosa will have a cobblestone appearance. Okay, cobblestone, पता है आपको? What is a cobblestone? Mostly when they repair these footpaths, no, it's a triangular shaped sort of stones they will use, and they will make the road or the footpath. Okay, the smaller stones, पूरा cement या इसका डांबर का नहीं बनाते ना, so they will use that different type of a stone. Okay, so that is called as a cobblestone. So cobblestone appearance, it will come to the intestinal mucosa because all these changes, inflammatory changes are occurring. I'll show you the picture. Okay, then as the disease advances, the bowel thickens and becomes fibrotic, and the intestinal lumen narrows, right? So diseased bowel loops, sometimes they will adhere to the other loops which are surrounding them. Okay, so is it clear? Pathophysiology, basically, remember it's an inflammatory
Yes, ma'am.
disease. Okay, inflammatory changes are subacute and chronic type, right? Then these inflammation is where it is again, it is called as regional enteritis. So it is some part of the bowel is affected. Okay, now these layers are when whatever part is affected, but it will involve all the three layers. Okay, all the layers are there, and that's why it is called as a transmural lesion. Okay, so that is present where in the intestinal mucosa. Fine. Now this inflammation, they are calling it as ulcer. So ulcer will be appearing on the inflamed mucosa. These lesions will these are not in continuous contact, so you will have separate lesions which are formed on the intestinal wall. If it continues, there will be formation of fistulas, fissures, abscesses. Okay, then in the go there may be granuloma formation, which will in the advanced cases, if it goes on continuing, it will give the intestine a cobblestone appearance. Okay, and as the disease advances, what happens? The bowel wall will thicken because of all this presence of the granulomas or the inflammatory changes. So it becomes fibrotic, and then slowly the intestinal lumen will narrow. Okay, so that is what basically happens in inflammatory bowel disease in the regional enteritis. So what are the signs and symptoms? See, now these inflammatory changes are happening, so it cannot happen immediately. It will take some time. That's why the symptoms, onset of symptoms, it is termed as insidious. Okay, insidious meaning it will develop gradually. It will not suddenly cause, symptoms in the patient. So, but what the patient will show, there will be prominent lower quadrant abdominal pain unrelieved by defecation. Okay, so even if the patient defecates, there is no relief of the pain. Then the patient may many times develop diarrhea, abdominal tenderness and spasm. Then the pain characteristic of the pain is, it is crampy type of a pain. When is it occurring? Mostly occurring after the meals. Okay, why does it occur after the meals? Because once the patient eats, it will stimulate the intestinal peristalsis. So intestinal movements, once it starts, it will cause pain to the patient. Okay, because there is inflammation within, so anything goes inside the intestine is causing problem to the patient. Then there is reduction in the food intake. There is weight loss, malnutrition. See, now malnutrition and weight loss, why this is occurring? Because this is affecting the intestine where your absorption of the nutrients as well as digestion, both things are taking place. So your nutrients are not getting absorbed. So that's why the patient will will start losing weight, and after a few months or a few period of time, the patient will go into malnutrition and also secondary anemia. It is called a secondary anemia. Secondary meaning which is because of this, because of the enteritis. Then irritating discharge into the colon due to the ulcers in the membrane lining of the intestine and other inflammatory changes will be present. Okay, so there is ulcer formation. So ulcer formation से क्या हो रहा है? There is some discharge, okay, which is keeping on coming out of the inflammatory changes what are there. So that irritation, that will cause a irritation to the colon. Then there is chronic diarrhea and nutritional deficit. As we already said, the patient may go into malnutrition. Then there will be abscess formations, fistulas, and fissures which may be present on the intestinal wall. And sometimes these inflammatory changes, they are giving out all the what you can say, the harmful material out, right? So this may go and get deposited on the other organs. Okay, so it may involve the joint. If it is involving the joint, it is called as arthritis. If it goes and affects the skin, it will form the skin lesions. It will be seen in the form of erythema nodosum, that is your erythemized redness. Okay, so nodules will be formed on the skin because of these deposits. Then ocular disorders, if it is affecting the eyes, it is called, it will be um, in the form of conjunctivitis or oral ulcers. Okay, so it will not just remain to the intestinal symptoms, it may also lead to the other organ involvement also. Okay, so these are the clinical manifestations of regional enteritis. How would be the assessment and diagnosis done? These are the yeah, these are the investigations. Okay, first you have proctosigmoidoscopy. Okay, so rectum and the sigmoid area both. So that is done with the help of proctosigmoidoscopy to determine whether the rectosigmoid area is inflamed. Secondly, patient may undergo stool examination, that is for occult blood and steatoria, that is your excessive fat in the feces that can be detected. Then barium study of the upper GI tract, that is, it shows the classic string sign on an X-ray film of the terminal ileum, indicating that there is a construction in the segment of the intestine. I'll show you what is the string sign. Okay, I think the next slide will be on. Yeah. So this is the string sign. So you have your loops of the intestine here, and in between, because of the inflamed area, there is the narrowing which is seen. So it is a very thin luminal contrast, usually in the terminal ileum from the, which happens because of spasm and the eventual fibrosis, which is seen mostly in the Crohn's disease. So this is called as a string sign. Okay, and we talked about cobblestone appearance. Na? So this is what I was telling you is the cobblestone. So this is the endoscopic figure of the intestine. So this is how the granuloma formation is there and solution formation is there. So it will give a cobblestone appearance. Okay. So that is seen in the barium study. Okay. So barium is basically not passing through this area. So it will cause a string of that particular area of the intestine. Then next is endoscopy. So endoscopy and the intestinal biopsy also can be done. So it will give the inflammatory changes will be seen in the intestinal cells. So this will be a confirmatory test for uh, uh, Crohn's disease. Then barium enema can be done. So where it will show ulcerations. So these ulcerations are formed in the form of cobblestone appearance, and it may further develop into fissure or fistula. Then next test is CT scan. So bowel wall thickening and fistula tracts can be detected in the CT scan. Also, complete blood cell count can be done. This is to assess the hematocrit and hemoglobin levels. Okay, because we said that there is a the patient's nutritional deficiencies will be seen, so that will be uh, checked out with the hematocrit values and the hemoglobin values. Okay, then there is an infection, so there is WBC count will be elevated. Then the sedimentation ESR, that is your erythrocyte sedimentation rate, will be usually elevated. Then again there will be absorption of the protein levels proteins are affected. So albumin and your general serum protein levels will be decreased, which will indicate that there is the patient is moving into malnutrition. Okay, so these are the various diagnostic findings. Next, moving on to the complications. So what are the complications? Intestinal obstruction or stricture formation can occur. Then perianal disease may be seen in certain patients if the infection moves on or it progresses to the other area. Then fluid and electrolyte imbalance, malnutrition from that is occurring because of malabsorption. Then fistula formation, that is normally it is an enterocutaneous fistula. So there is a connection formed between the small bowel and the skin. Then abscess formation can occur, and the patient again, if it is a chronic thing, then the patient will be having increased risk for colon cancer. Okay, so these are the complications. That was the first type, that is regional enteritis. Second part of the second type, it is called as ulcerative colitis. Okay, so what is the changes which are seen in ulcerative colitis? So colitis, again, this is also inflammation. Ulcerative, so there is formation of ulcers. So it is a recurrent ulcerative and inflammatory disease of the mucosal and submucosal layers of the colon and rectum. So which ages are affected? Mostly 30, between 30 and 50 years of age. It is a serious disease accompanied by systemic complications and a high mortality rate. Then eventually 10 to 15% of the patients may develop the CA colon. Okay, so that is introduction of ulcerative colitis. Now what is the pathophysiology? Okay, so here ulcers are formed where on the mucosa, no? Ulcerative colitis. So what is affected? The mucosa. Which mucosa? Superficial mucosa, which is of the colon is affected. So what happens because of that? Okay, there may be multiple ulcerations, diffuse inflammations, and desquamation, or there will be shredding of the colonic epithelium because of these inflammatory changes and these ulcer formations. Okay. Now, these ulcers are formed fine, but then there may be also bleeding. There is a blood supply to the mucosa, no? So there is a bleeding which will occur as a result of these ulcerations. Then the mucosa becomes edematous and inflamed. The lesions are contagious, occurring one after the another. Then this abscess formation plus there will be infiltrate which is seen in the mucosa and submucosa with the clumps of neutrophils in the crypt lumens. Okay, they are called as crypt abscesses. So disease process usually begins in the rectum and then spreads proximally to the entire colon. Okay. So eventually what will happen? There will be the narrowing of the bowel, shortening of the bowel, and it will thicken because of muscular hypertrophy and the fat deposits. Got it? So here pathophysiology, remember how it will progress. It will start from the rectal area and then it will move ahead to the other part of the colon. Okay, there will be what is affected here? Superficial mucosa of the colon is affected. Formation क्या है? Ulcerative colitis. So there is formation of the multiple ulcerations, diffused inflammations, and desquamation is seen. Okay, bleeding may be seen from these ulcers, and there is edema and inflammation. So again, this will progress. So what is for the seen? What changes are seen on the mucous membrane? That is abscess formation, infiltrate in the mucosa and submucosa with the clumps of the neutrophils in the crypt lumen. So that's why they are termed as crypt abscesses. Okay. So eventual, what is the end output of this disease? The bowel will narrow, shorten, and thicken because of the muscular hypertrophy and the fat deposits. Fine. So what are the clinical manifestations? Clinical manifestations, first is again this will also be in the form of exacerbation and remission. Then there will be diarrhea, lower left quadrant abdominal pain, intermittent type of tenesmus, that is the pain in the bowel. So there is intermittent tenesmus will be seen. Then there is rectal bleeding, which may be mild or severe depending type of or the severity of the disease. Then there will be pallor. Why pallor will be developing? Because there is bleeding, no? So there is,
Please.
yeah. So because of bleeding, the patient will turn pale. Then, so pallor, how will you elicit? How will you identify the patient is having pallor?
Check the capillary refill.
Yes, capillary
Capillary
leak.
refill.
Okay,
Uh, mm,
that is one way. Then other way, where all you will find pallor. Yes.
ma'am, inner eyelids, ma'am. We check the
Yeah,
inner eyelid.
yeah, yeah,
With
in the mucosal membranes. No, so mucosal membranes where one is your eyelids and secondly in your oral cavity. Okay, if you and even
yes, ma'am.
overall pale appearance of the patient will also tell you that the patient is having pallor. No, one is your mucous membrane, and secondly your nail beds, which will tell you the peripheral pallor. Hmm? Then anorexia and weight loss, fever, vomiting and dehydration. Then there will be cramping and a feeling of an urgent need to defecate. So here the patient may even pass 10 to 20 liquid stools each day. Then there is hypocalcemia and anemia, again frequently seen in the patient because there is again we said there is absorption is affected. Then there may be rebound tenderness which may occur in the right lower quadrant. Okay. Extraintestinal symptoms kya hai? What we said earlier, if there is other involvement. So there may be skin lesions, eye lesions, or joint abnormalities, and even liver disease. Okay, so these are the clinical manifestations. What about the diagnosis? So first is we have to assess the patient for whatever symptoms first of all we have seen. So your major symptoms may be tachycardia, hypotension, tachypnea, fever, pallor, level of hydration if the patient is having diarrhea. Hmm. Then assessment of the nutritional status. Apart from that, abdominal examination is mandatory. So characteristics of the bowel sound, distension and tenderness. And what all tests need to be done? One is stool examination that will be positive for blood because of the inflammatory changes. There may be even blood loss from the stool. Then hematocrit and hemoglobin concentration would be low. WBC count, it may be elevated. There is again loss of protein, so albumin levels will be low. Electrolytes imbalance is seen, so because of the passage of the excessive amounts of stool. So the serum electrolyte imbalance. Abdominal X-ray may be done, but not a confirmatory diagnosis. But these investigations, that is sigmoidoscopy or colonoscopy, would be confirming the diagnosis. Also, barium enema can be given, so it will tell about the, or it will elicit, or it may show the mucosal irregularities, focal strictures or fistulas, shortening of the colon, and the dilation of bowels. Okay, so that's how the diagnosis can be done. Clear? So what
Yes.
complications may be seen? Okay, either the patient may land up into toxic metacolon, or there may be perforatory changes. So perforation, bleeding, this is all occurring. Why? Because there is ulcer formation. So because of ulceration, vascular engorgement, and highly vascular granulation tissue. What are the signs? What are the symptoms of these? Whatever we have seen, these complications, how they have to be identified. The patient develops any fever, any abdominal pain, any distension, any vomiting, and fatigue. Okay. Then colonic perforation from the toxic metacolon is associated with a high mortality rate. So even 15 to 50% of the patients may lose their life because of these complications. And then there is increased risk of osteoporotic fractures due to the decreased bone mineral density. So there is also calcium intake is affected. So the absorption is affected. So there is the difference in the bone mineral densities that may cause the osteoporotic fractures to the patient. Then these patients may be also put on long-term corticosteroid therapy. So even corticosteroid therapy has a side effect of diminished bone mass. So these would be the complications in these patients. So how are these managed? First is the nutritional therapy. So taking care of the intake of the patient. So oral fluids have to be given to the patient. Then you cannot give a full diet to the patient. So there will be low fiber diet has to be given. That is called as a low residue diet. Then, as we know that we said that there is a loss of the proteins, loss of albumin. So high protein diet, high calorie diet has to be provided with the supplemental vitamin therapy and iron replacement, which are prescribed to meet the nutritional needs, reduce the inflammation, and control the pain and diarrhea. Okay, so that is first and foremost, we have to take care of the diet. Now also we have to not only the diet but have an eye on what are the fluid levels, what are the electrolyte imbalance happening in the body. Okay, why this would be occurring? Because of the dehydration, because the patient is passing excessive stool, so that is the patient is having diarrhea. So which are how it will be corrected by giving intravenous therapy. At all if the patient is admitted, but if the patient is at home, then again at home also fluid electrolyte balance has to be maintained, has to be taken care of. The patient needs to be explained about the oral supplementation. Then any foods that will exacerbate diarrhea should be avoided. Okay, like for example, if the patient is having the lactose intolerance, so milk should not be given to these patients. Also, avoiding the cold foods and smoking as both increase the intestinal motility. Okay, so they have to if all the patient is a smoker, we said many of the patients are smokers, no, it is more found in the smokers than the non-smokers, so this also has to be taken care of. Then parental nutrition may be indicated in certain patients who may not tolerate the oral foods. Okay, and what drugs are required for these patients? First, of course, sedatives may be given to the patient. Then antidiarrheal drugs and the antiperistaltic medication. Antiperistaltic meaning which will reduce the intestinal motility. Okay, so it will minimize the peristaltic movements. Why this is done? To give rest to the inflamed bowel. See, whenever there is inflammation, you need to give some rest to that area, no, so that it will it can start healing. So they are continued until the patient's stools approach the normal frequency and consistency. Then certain sulfa there's a mistake there. Okay, formations like sulfasalazine, these are given in case of mild to moderate inflammation and to prevent the infections. Okay. Secondly, there are aminosalicylates. Okay. For example, mesalamine, there is a typing mistake here. Okay, these aminosalicylate is here. Example, mesalamine, uh, which will prevent and it will help in treating the recurrence of inflammation. Then antibiotic patients have started on antibiotics if at all there is a secondary infection, especially the purulent complications such as abscesses, perforation, and peritonitis. Uh, then patient could be put on corticosteroids, for example, orally. It may be given either in the oral form, injectable form, or in the topical form. Topical meaning, for example, in rectal administration. So if it is an oral, so prednisolone may be given in cases where there is a severe and permanent disease. Then there is topical, that is the rectal administration of corticosteroids also may be given in the case of if their distal colon disease is present. Then what is the problem with these corticosteroids now? See, the corticosteroids you cannot just immediately stop. So it has to be either reduced or slowly tapered and then stopped. So, but if at all it is stopped or reduced, what may happen in the patient? It will cause again the recurrence. So the symptoms of the disease may return. So if the corticosteroids are continued, adverse sequelae like hypertension, fluid retention, cataracts, okay, hirsutism, that is the abnormal hair growth, adrenal suppression, and loss of bone density may develop. There are certain immunomodulators, for example, azathioprine. You might have heard of this drug, no? Azathioprine. Then the other drugs like 6-mercaptopurine, methotrexate, cyclosporine, all these have been used to alter the immune response. Okay, so these may be the drug therapy for the patient. If the patient is not responding to the drug therapy, the patient may undergo a surgical management also. So around 15 to 20% of the patients may undergo a surgery. So what are the surgeries which are done? One is total colectomy and ileostomy. Fine. So here, as the word tells you, total colectomy. So your colon is full, your colon is removed. Also the because there's no opening for, or there is a opening for your stools to come out. So what they will do, they will create an ileostomy. So after the colectomy, the ileum will be pulled out on the skin and an ileostomy is made. That is one thing. Secondly, intestinal transplant can be done. Okay. So this intestinal transplant, again, it is a newer surgical procedure which is developed for the patients with severe regional enteritis. So it will provide improvement in the quality of life for some who are terminally ill. Okay, so that is intestinal transplant. Third type of surgery which the patient may undergo would be called as proctocolectomy with ileostomy. So that is complete excision of the colon, rectum and anus. This may be recommended in the patients when the rectum is severely involved. Okay. Next called as stricture plasty. Stricture plasty में क्या करते हैं? Whatever stricture meaning what is the narrowed part, no? So or the blocked section of the bowel is widened, and they will because the bowel is widened, then it will your bowel lumen will remain intact. So it will help in the whatever removal of the contents. So that is stricture plasty. Next is the surgical removal of the small bowel. So in 50% of the patients, this can be tolerated. Okay, or other surgery which can be done is the fecal diversions. Okay, fecal diversions is to be wherever is the inflamed part that you um, have to bypass and then create the what you can say small openings where you can move the fecal outside. Okay, so that is your fecal diversions. Another choice of surgery is so one we said first, in fact we said is the total colectomy with ileostomy. So what is done here, you can see, you know, so this colon, this is a partial colectomy, but you can have a whole colon which can be removed, and whatever is the ileum that can be pulled out, and they will create a stroma here. Okay, so ileostomy is a surgical resection of an opening into the ileum or the small intestine, usually by means of ileal stoma on the abdominal wall, which is commonly performed after a total colectomy. So it will allow for drainage of the fecal matter that is effluent from the ileum to the outside of the body. The drainage mostly is mushy and it will occur at the frequent intervals. Now, second type of surgery is called as total colectomy with continent ileostomy. Okay. So what is this? It involves the removal of the entire colon and creation of the continent ileal reservoir. Okay, it is called as the Cox pouch. But you can see here. Okay, so you have the Cox pouch. Okay, how it is created? This procedure, it will eliminate the need for an external fecal collection bag. So how you have in this surgery you have a stoma bag which is outside. Okay, here are internal only you prepare one reservoir for that internal fecal content. Okay, that is called as a Cox pouch. So here approximately 30%, 30 centimeter of the distal ileum is reconstructed to form a reservoir with an wall that is created by pulling a portion of the terminal ileal loop back into the ileum. Okay, so that's how this Cox pouch is created, and there is an opening on the skin you can see. Okay. So the GI effluent can accumulate in the pouch for several hours and then can be removed by the means of a catheter which is inserted through this valve. Okay. So this is a valve created here, and you have a tube for the catheter which can be inserted into this Cox pouch. So when this at frequent intervals, you can do, you can just put the catheter and clean up the ileal contents. Okay, so that is total colectomy with the continent. It is called as continent ileostomy. Okay, continent ileal reservoir को क्या बोला है? It is called as a Cox pouch. Next type of surgery is called as total colectomy with the ileoanal anastomosis. Now, total colectomy understood with ileoanal anastomosis. Ileum to the anus. Okay, ileoanal anastomosis. So here again there is no need of any colostomy which has to be brought out on the patient's skin. So it establishes an ileal reservoir and an anal sphincter control of elimination is retained. So the procedure, what they will do, they will connect the portion of the ileum to the anus, that is called as ileoanal anastomosis, in conjunction, that is along with the removal of the colon and the rectal mucus. So there is total abdominal colectomy and mucosal prostatectomy, that is called as. Okay. So here what they will do, the temporary diverting loop ileostomy is constructed at the time of surgery. So even if ileostomy is there, that is for temporary time, and then it will be closed about 3 months later. Okay, why that is done? Because this will require this ileum. It will take time to heal, no? Because it has to instead of bowel now it has to start functioning. So to make it functioning, they will give rest to this surgical whatever intervention what is done. Okay, so they will prepare make an ileostomy so the patient can keep on eating and that will move out the ileostomy. By the time in the 3 months period this is going to get healed, and then it will be prepared, this part will be prepared for the normal passing of the stools. Okay, there's a difference in the passing of the stools, but at least the bowel function, some of the bowel function is what I can say is preserved. So with ileoanal anastomosis, the diseased colon and rectum are removed and voluntary defecation is maintained and anal continence is preserved. Okay, so the ileal reservoir decreases the number of bowel movements by 50% from approximately 14 to 20 per day to 7 to 10 per day. Okay, nighttime illumination is also gradually reduced to one bowel movement. Okay, because it cannot have total how you have in your large bowel, na? So that may not be exactly same, but then the frequency will be more than a normal thing, but which was there earlier in the disease condition like 14 to 20 per day, it will reduce to 70 per day, 10 per day. In the complications of ileoanal anastomosis, it may include irritation of the perianal skin from the leakage of fecal contents, or there may be stricture formation at the anastomosis site, or there may be small bowel obstruction. So even if this surgery is done, they will have to keep a follow-up if this reconstruction is in a working condition or not. Okay, clear surgical part?
Yes, ma'am.
Yeah. Okay, so what surgeries? Just to take a quick look: total colectomy with and ileostomy, intestinal transplant. Sorry, uh, proctocolectomy with ileostomy, streptoplasty, surgical removal of the small bowel, fecal diversions. Then colectomy can be with uh, permanent ileostomy, or it can be a continent ileostomy, or it can be done with the ileoanal anastomosis. Okay, what about the nursing process? These are the likely diagnosis in the patients. क्या है? First diarrhea, which may be related to the inflammatory process, acute pain, which is related to the increased peristalsis and GI inflammation, and deficient fluid volume, that is because of anorexia, nausea, and diarrhea, imbalanced nutrition, which is less than body requirements, related to the dietary restrictions, nausea and malabsorption, activity intolerance related to fatigue, anxiety related to impending surgery, ineffective coping related to repeated episodes of diarrhea, risk for impaired skin integrity related to malnutrition and diarrhea, risk for ineffective therapeutic regimen management related to insufficient knowledge regarding the process and management of the disease. Okay, the likely potential problems: electrolyte imbalance, cardiac dysrhythmia related to the electrolyte depletion, GI bleeding and fluid volume loss, and perforation of the bowel. Okay, this is the difference between the regional enteritis and ulcerative colitis. Okay, regional enteritis normally it is prolonged and variable. There is ulcerative colitis, there is exacerbation and remission. Pathological changes in enteritis, there is transmural thickening, there is penetrating granulomazacin. In ulcerative colitis, there is mucosal ulceration and mucosal minute ulceration. Signs and symptoms: again, here the ileum or the right colon is affected. Here the rectum and the left colon is affected. Bleeding, it may not be much seen in the regional enteritis. So here it is commonly seen and it may be severe. Perianal involvement is common in regional enteritis. It is not seen in ulcerative. Fistula is also common here. Then the rectal movement is more in ulcerative colitis. Diarrhea is severe in the ulcerative colitis than the regional enteritis. Okay. Investigations: radiography, sigmoidoscopy, colonoscopy. Already I've told you what is seen in either of these, so I'm not going again into that. मैनेजमेंट कैसा करना है? रीजनल एंटेराइटिस, कॉर्टिकोस्टेरॉइड, सल्फोनामाइड्स, एंटीबायोटिक्स, पैरेंटल न्यूट्रिशन, partial or complete colectomy with ileostomy or anastomosis, and again this is recurrence may be seen. Ulcerative colitis, how it is managed? Corticosteroids, sulfonamides, sulfasalazine. This will help to prevent the recurrence. Then certain bulk hydrophilic agents can be given to increase the consistency of the stools. Then antibiotics, proctocolectomy with ileostomy, and other surgical interventions what we already saw. So here the rectum can be preserved in only few patients which are cured by the colectomy. Complications seen here is small bowel obstruction, right-sided hydronephrosis, nephrolithiasis, polylithiasis, arthritis, retinitis, iritis, and erythema nodosum. Similarly here, all the rest what we said joint and again seen here, including your renal involvement. Then it may develop into malignancy. So malignant neoplasms, hemorrhage, perforation, and toxic megacolon. Okay, these are the systemic complications which are seen in either of these conditions. Okay, now this is your assignment for today. Write down: nursing management of the patient requiring ileostomy. Okay, I think you can find this in Brunner also. Majority of the stuffs I'm taking from Brunner and Harrison, and one more book, Essentials of MedSurg. Okay. Now one more topic I think I can be able to complete, that is acute GI bleeding. sorry, acute GI bleeding is not for you all. It is in the it is in the second year, but you have gastrointestinal bleeding. Okay, to just to give an idea of know what is the classification, this is what I just want to show you first. Okay. See, when you have gastrointestinal bleeding, it can be in the, it is classified as upper GI bleeding and it can be a lower GI bleeding. Okay, how they decide on whether it is upper GI bleeding or it is a lower GI bleeding, it is based on this. That is a ligament of Treats. Okay, ये कहाँ है? This is your abdominal cavity. If it is cut horizontally, what you can see here. Okay, ये क्या है आपका? This is your esophagus. Okay, this is what? This is your this is your right crust of the diaphragm. That is a part passing to the right of the esophageal hiatus. Okay, then this is the, okay, ये आपका आ गया right वाला और ये आ गया आपका left crust of the diaphragm. Okay, that is a part which is passing to the left of the esophageal hiatus. Then there is this is what is the celiac trunk. Okay, your blood vessels which are, or the celiac arteries which are going to provide the arterial supply to the abdominal cavity. Okay, this what you can see here is the ligament of Treats. Okay, this is your ligament which is going to separate it from your upper GI tract and the lower GI tract. Okay, so here below this ligament you have the duodenojejunal flexure. So आपका esophagus है, abdomen ऊपर आ गया, नीचे क्या है? You have your duodenum, jejunum and the rest part of your intestines. Okay, so ahead below down, तो ये तो आपका खाली duodenum and the, so the ascending part of the ascending part of the duodenum and then continued into the jejunum. Okay, so for this classification, you have to remember this ligament of Treats. So it is above the ligament of Treats, it is called as upper GI bleeding. If it is below that, it will be called as lower GI bleeding. Clear?
Yes, ma'am.
Okay. We don't normally talk about ligaments, muscles and all, no? Yes, but to understand this, the classification, if you see in any books, it will talk about the ligament of Treats. So how this patient is present, what is the presentation? Presentation meaning uh, how will you identify a patient who is walking in and he is developed a GI bleed? Yeah, visible. Okay. So one is hematemesis. Hematemesis, you know what is hematemesis, no? See, it is above the ligament of Treats. That means your upper GI tract. And lower है तो lower GI tract. तो upper आएगा तो vomiting आएगा, lower आएगा तो there is the stool characteristics you have to remember. Okay, that is the difference. So if it is upper, then the patient may have hematemesis, that is vomiting of blood and blood or altered blood, that is the coffee ground color of blood will be seen, indicating that is the bleeding proximal to the ligament of Treats. Second, melena, that is altered black, that is it is blood in the which is, okay, blood which is seen in the which is coming out per rectum. So it is the color of the stools will become black. It is called as melena. Okay, so it is melenic stool wherein there is more than 100 ml of blood which is required for per stool. So it usually indicates bleeding proximal to the ligament of Treats, but may be as distal as descending colon. Pseudomelena, which may be caused by the ingestion of iron, bismuth, lysoris, beads, blueberries, or charcoal. Okay, so this is not pseudomelena. Pseudomelena मतलब क्या है? Pseudo means what?
False.
Yeah, pseudo means false. So you may have the discoloration of the stools whenever the patient is taking, for example, iron tablets. Na? or the patient has taken bismuth for some treatment, or the other eatables, say, yeah, beets, blueberries, charcoal, anything. But that is called as pseudomelalia. But when you really have like, blood in the stools, then it will be called as the proper melena. So in that case, there will be more than 100 ml of blood. Okay, to call it as melena. Otherwise, it may be just what a small amount of blood. You will not call that particular stool as melena. Then hematochezia. Here there is a bright red or maroon rectal bleeding which you see, which usually implies bleeding beyond the ligament of Treach, but may be due to rapid upper GI bleeding. If the bleeding is more than 1000 ml and so there is a bright red maroon type of rectal bleeding which is in fresh bleeding हो जाएगा. So that is called as hematochezia. Okay. Then there can be, if they do the fecal test or the stool test, it will be positive for the blood. So blood is present in the stools. That's why it is called as positive fecal occult blood test. Okay, it may be with or without the iron deficiency. Then symptoms of blood loss will be seen that the patient may be having lightheadedness or the patient may have shortness of breath. Okay, that is how a patient will present with a GI bleed. Yeah, because there is bleeding. Okay, if you have fresh bleed and all, so there will be automatically there will be certain hemodynamic changes. So there will be drop in the blood pressure, mostly orthostatic drop in the blood pressure, which is more than 10 millimeter of mercury. Usually indicates more than 20% reduction in the blood volume. Okay, so there may or may not be presence of syncope, lightheadedness, nausea, sweating, and thirst. Then the patient may move into shock, that is, the blood pressure will be less than 100 millimeters of mercury. This systolic usually indicates less than 30% reduction in blood volume. So the patient may or may not present with pallor, cool skin, cool clammy skin. Okay, that is when the patient is moving into shock. Then laboratory changes. Hematocrit levels may change, but it may always not tell that there is how much blood loss is happening. So this is because of delayed equilibration with the extravascular fluid. Hmm. So that is hematocrit levels may be changed. Secondly, there is leukocytosis and thrombocytosis. Okay. Then blood urea nitrogen levels may be also elevated, which is more commonly seen in upper GI bleed. Okay. What are the adverse prognostic signs? Here, adverse prognostic signs means if the patient is having these conditions, the prognosis or the patient's recovery may not happen. So, the patient may not come back to a normal thing. So, it is age is more than 60 years, associated illnesses like the patient may have coagulopathy, immunosuppression, presentation with shock, rebleeding, onset of bleeding in the hospital, variceal bleeding, endoscopic stigmata of the recent bleeding, like for example, there may be visible vessel in the ulcer base. So either of these conditions, the patient may not have a good prognosis. Okay. So the types of bleeding क्या है? It can be either an upper GI bleeding or a lower GI bleeding. Upper GI bleeding का cause क्या है? Anything which is related to your stomach. So one is more than 50% of the patients would have the cause of peptic ulcer. They are suffering from peptic ulcer disease. Then gastropathy, which may be caused because of drugs like your alcohol, aspirin, and the other NSAID drugs being said. Then stress, of course, important factor, esophagitis. Then there is something called as Mallory-Weiss tear, that is the mucosal tear of the gastroesophageal junction due to retching, and there may be gastroesophageal varices. Varices are the bleeding points which may be present, okay, and that will cause bleeding on the surface or the mucosa of the gastroesophageal, meaning either in the stomach or in the esophagus. The causes of this. So upper GI bleeding, it is less commonly seen, but however it may be having because of swallowed blood
Hello? Hello? रश्मी सायली
हॅलो. बोल.
मॅम लेफ्ट झाली का?
हा हा
लॉस कनेक्शन आलंय.
ओके
येईल
ओके
परत.
ठीक आहे. मग काय चाललंय?
काय
अरे यार, मला
लेक्चर
नाही
चालू
अरे
आहे.
बाउन्स एक साथ बाउन्स जात है.
मला खूप यार
एक
खरं हे जी आहे
जास्तच
तर मी
झालंय जरा
काहीच
आज.
नाही जात आहे. हो खरंच.
एक
जिया.
दोन आपण डिफिकल्टी समजू शकतो. हे तीन तीन एक साथ एकदम बाउन्स जातात.
हा ना.
हा ना. आणि
जाऊ दे.
असाइनमेंट सगळे लिहिले तुम्ही दोन्ही?
असाइनमेंट दिले आहेत आपण सबमिट करून टाकूया.
हा मला
Hello.
येस मॅम.
Yeah, I think.
येस मॅम.
Hello.
येस मॅम.
येस
Yeah,
मॅम.
I have it to my mail, but then be able to show you the slide. Uh, okay, I think I'll continue. Fine. I can share you the slides later on. Fine. Yeah. So the upper GI bleeding causes. There's they said this upper GI bleeding is less common. The other causes, what I told you, was swallowed nose, that is the nosebleed, then esophageal, gastric, or the intestinal neoplasms, anticoagulants and fibrinolytic therapy, hypertrophic gastropathy, then it is called as Menetrier's disease, then aortic aneurysm, uh, then you have AV malformation, then something called as telangiectasis, that is osseous Weber syndrome is called as. Then there are other problems like vasculitis, then connective tissue diseases. Those are called as one is pseudo xanthoma elasticum and Ehlers-Danlos syndrome. Okay. Then blood dysplasia and neurofibroma, amyloidosis and hemophilia. That is it is having the biliary origin. So that is the common causes of the GI bleeding. Then how these patients are evaluated. First is on the basis on the history and physical examination. That will include the drugs. Okay, so increased risk of upper and GI bleeding with those aspirin or NSAIDs or any prior ulcer or there's any bleeding history has to be found out, any family history of the patient and features of the cirrhosis or vasculitis. Just one sec, I think I have regained the connectivity. I will join from there. Yes, you can hear. Slide is visible. Hello.
No, ma'am.
No, ma'am.
Okay. Now it is visible. I
Yes,
think.
ma'am. Yes.
Yes,
Okay.
ma'am.
Fine. So we first is the. Am I getting an echo? Can you hear an echo?
Yes, ma'am.
1 minute. Hello. Better. Hello. You can hear me?
Yes,
Yes,
ma'am.
ma'am.
Okay. And slide is also same. Fine. So there may be hyperactive vowel sounds which may favor the upper GI source. Then there will be nasogastric aspirate may be taken to find out for gross presence of gross blood and find out whether it is an upper or lower GI bleed. Okay, then testing the aspirate for the occult blood, it is meaningless. So that is not used. Then upper endoscopy can be done. Here it will have accuracy of 90%, allowing the visualization of the bleeding site, and it will again it can be also used as a therapeutic that for the treatment purpose it will be used. Okay. Uh, Other investigations like upper GI radium radiography, which can be which is having accuracy of around 80%, and it will help to identify the lesions, though it will not confirm the source of bleeding. Then selective mesenteric arteriography can be done. So when there is brisk bleeding will preclude the identification of the source at endoscopy. So selective mesenteric arteriography means if at all they identify which artery is bleeding, okay, so that can be assessed with the help of endoscopy. Then radioisotope scanning. So technetium, that is the radioactive isotope which is used. So it will be tagged to the red blood cells or the albumin, and it would be used primarily to screen the test as a screening test to confirm the bleeding, which is rapid enough for arteriography to be of value, or when the bleeding is intermittent or of they don't know from where exactly the bleeding is happening. So radioisotope scanning will tell you the exact bleeder. Okay. So how it is managed? If it is an ulcer, okay, if it is active bleeding and visible vessel hai, so they will give the proton pump inhibitor therapy, and endoscopic therapy can be done. And the patient will be admitted for ICU for 1 day, and next after can be moved for in the ward for 2 days. Okay. Then if there is an adherent clot, then again same PPI therapy with and without or without endoscopic therapy, and the patient will be admitted in the ward. Thirdly, if the patient if there is plant pigment spot, then no IV is given. IV PPI is given, or there is endoscopic therapy not required, just admitted in the ward. If there is a clean base, that means कुछ problem नहीं है, it is not a severe ulcer, then the patient would be then further if the patient is discharged. Okay. If the patient is having esophageal varices, then the ligation of the varices will be done and they will be given the vasoactive drug. Okay, drug of choice is octreotide. Then the patient here will be in ICU and then will be shifted to the ward. If there is a Gallery vis there, तो क्या करना है? To find out whether there is active bleeding or no active bleeding. So either the patient will go undergo an endoscopic therapy with no active bleeding, then no endoscopic therapy. Okay. So either in the ward or the patient would get discharged. Okay. That is how the management can be done. This is the flow chart or the algorithm. It is called as algorithm. Okay. For the patient who are having acute upper GI bleeding. Okay, I have written the reference. Then, if it is a lower GI bleeding, then what are the causes? It can be anal lesions, that is hemorrhoids or fissures, rectal trauma, proctitis, colitis. So colitis we saw, Crohn's disease, ulcerative colitis, or it can be ischemic infectious or radiation because of radiation. Then colonic polyps, carcinoma, CA of colon, angiodysplasia, that is the angiodysplasia is the vessels, blood vessels are affected in this. Okay. Then diverticulosis, intersusception, single ulcers, solitary ulcers, then blood dysplasiasis, vasculitis, connective tissue disease, neurofibroma, amyloidosis, and anticoagulation therapy. So this either of these are the causes for lower GI bleeding. How they would evaluate this patient? One is of course physical history and physical examination. Then there may be hemodynamic changes. They may undergo an endoscopy followed by colonoscopy, and they will exclude if there is any hemorrhoid, fissure, ulcer, or proctitis, or any neoplasm which is present. So then these patients may be undergoing colonoscopy. If again there is the bleeding is massive, then it is not possible. Then barium enema can again, in case of if it is active bleeding, then again it is of no use. Arteriography, what we said earlier, it may be done. So this may be when bleeding is severe, then it will tell you the site of bleeding and any abnormal vasculature. And surgical exploration, that means they have to open up the patient and find out where the bleeding is happening from. Okay, that is how they will be finding it. Now if the bleeding is of obscure origin, so often small bowel, it may be a small bowel. So consider for small bowel enteroclysis X-ray, then there can be a Meckel scan, there can be enteroscopy, that is the small bowel endoscopy, or exploratory laparotomy may be done with the intraoperative enteroscopy. Okay, so that will help to find out the bleeding. Now, if the patient is hemodynamically stable or hemodynamically unstable, so lower GI bleeding kaisa karna hai? How they will manage? If there is no hemodynamic changes and if the patient is less than 40 years, so there is flexible sigmoidoscopy. Okay, so this is the colonoscopy if the iron deficiency anemia, familial colon cancer, or the Focis protein is there. If the patient is more than or equal to 40 years, then the patient will undergo colonoscopy. Even if the patient is not stable hemodynamically, upper endoscopy, and then the patient will also have to undergo a colonoscopy, right? So again, this colonoscopy is done when if the massive bleeding does not allow time for the colonic lavage. Okay, then the patient may even go for arteriography. So if the site is identified, bleeding stops. If the site is identified and the bleeding persists, then again go for angiography. Okay. Bleeding persists, then surgery. Site not identified, bleeding persists, then the obscure bleeding workup. So find out what is the problem and accordingly manage. Okay, so that is the management for acute lower GI bleeding. Okay. But so how it is managed whenever the patient is either in the ward or in ICU, we said. So venous access, first of all, so getting a large, so central venous access mostly is done for the patient. Okay, then monitoring the vital signs, urine output, hematocrit levels, then GI gastric lavage. Again, it may not benefit but it clears the stomach before endoscopy. Then iced saline will help to lyse the clots if at all there is clot formation because of bleeding. And room temperature tap water also may be used for the gastric lavage. Then intubation can be done to protect the airway. And if blood has to be given, then typing and cross matching of blood is required. So 6 units for major bleeding may be required. Then surgical standby when the bleeding is massive. Then support the blood pressure with isotonic fluids, that is the normal saline, albumin, and FFP is given in the, if at all the patient is also cirrhotic, that means if any bleedings are there. Then packed red cell RBCs when available. So whole blood if massive bleeding is there, to maintain the hematocrit levels, and FFP, that is a fresh frozen plasma, and vitamin K to reduce the bleeding has to be provided. Okay. IV calcium may be given. Okay, so calcium 10% calcium gluconate IV can be given for 10 to 15 minutes if the serum calcium level falls. Okay, other drugs, antacids, and H2 receptor blockers, omeprazole can be given. And other specific measures like if at all varices hai to octreotide, it is given bolus or in infusion for 2 to 5 days. The Sengstaken Blackmore tube may be used. Nowadays it is not so much used, but they will go for endoscopic correction. Then band ligation if there is varices present. Then propranolol or nadolol is given in doses sufficient to cause the beta blockade. Okay, it will reduce the recurrent or initial variceal bleeding. Then if it is an ulcer with visible bleeding, तो क्या करना है, और active bleeding है तो they will do endoscopic or bipolar heated probe or laser coagulation. They will inject the epinephrine. Okay, if gastritis is there, then embolization of vasopressin, infusion of the left gastric artery. Then if there is telangiectasis, there is ethinyl estradiol or non-ethistron is used, given for orally, may prevent the recurrent bleeding. Okay? And diverticulosis is mesenteric arteriographine with the intraarterial vasopressin may be given. Then if the cause is angiodysplasia, then they will use a colonoscopy, and it is bipolar or laser coagulation may be done. Okay, then this may be indicated when wherever there is uncontrolled bleeding, or prolonged bleeding, severely bleeding, and arterioenteric fistula. Okay, so this for intractable variceal bleeding, they will consider doing the TIPS. Heard of TIPS? That is transjugular intrahepatic portosystemic shunt. Okay, this is the management for either the upper or the lower GI. Okay, is it clear?
Yes, ma'am.
Yeah. Okay. So anyhow, you may have to go back and read it again to understand full of acute GI bleeding. Yeah, because there are so many causes. You don't have just one cause to it, no? Okay, fine. So what else I wanted to tell you all? Uh, okay, the rest you have your syllabus. Just see the GI system in that, whether you want me to take the rest of the conditions which is given there, or you can do a self study. वो मुझे बताओ.
Okay, ma'am.
Okay. Fine. Okay, I'll leave.
हॅलो.
हॅलो.
काय करायचं तर.
मॅम गेली ना आता.
आपल्या
एक्झिट
सिलेबस मध्ये
केलं तिने.
डिस्कंडिशन हे नाही आहेत ना?
काय
आपल्या सिलेबस मध्ये डिस्कंडिशन नाही आहेत ना मेन्शन
डिसीज
केलेल्या?
कंडिशन नाही ना मॅम. मॅमला
नाही.
सांगायला हवं.
हो ते सांगायला लागेल. उद्या सांगूया.
हा चालेल.
चालेल चालेल. चला बाय.
बाय.